little bit different perspective that you guys are used to. So let's just start reviewing some basic concepts. Many of you have heard the concept of preload and afterload with relation to hemodynamics. Where do those terms come from? Well, back in the 1800s and the early 1900s, when they were doing the experiment with physiology, they would take a little piece of muscle from a frog leg. They would take a little bit of frog leg muscle. They would put a little weight on it, and they would connect it to a battery. When they connected the weight, the muscle would actually stretch itself a little bit, and that would call that the preload. Okay, so the term preload comes from the stretching of the muscle, and that would be consistent with the preload. Then they would actually connect the battery and throw the switch, and the muscle will contract and it will lift a little weight. And that weight that it was lifting was called the afterload. And it was actually lifting a little weight, okay? Okay, now those two terms, when you look at them from the cardiovascular point of view, correspond the preload to what we call the wedge, which is the amount of fluid that you put on the heart, which distends the heart, essentially stretching the heart muscles. And when the heart begins to contract and it meets a resistance outside the aortic valve, that resistance we call the afterload, because it's the resistance against which the heart has to pump against, okay? So the term preload and afterload come originally from the experiments that they were doing with electrophysiology and with muscle physiology back in the 1900s, when they were beginning to discover electricity, and everybody was going really crazy with electricity, and they were discovering that the muscle would contract and it would have the preload and afterload, and those terms actually translate into preload as wedge nowadays, and afterload as the resistance that the heart muscle has to push against when the aortic valve opens. Is that clear so far? Okay. Now, more recently, a guy named Brownwell, who's a very famous cardiologist and electrophysiologist at Baylor. Dr. Barquette, I'm in the middle of a lecture right now. Okay, so he began developing a series of experiments, and what they did is they took an isolated heart preparation. They took a heart, they transected the aorta, okay, and they clipped it. They put a probe into the aorta and a pump, and they connected that to a computer. They did the same thing with the left ventricle. They put a probe on the left ventricle to measure pressure, and also a big pump, and connected also to the computer. And they told the computer, we want you to, when the heart contracts, either take blood out of the aorta really fast or pump blood into the aorta really fast, so you can control the pressure inside the aorta. By the same token, they told the computer, when we tell you and the heart contracts, we want you to either give it fluid, so you increase the wedge or the preload, and at the same time, if we tell you take fluid out, so you decrease the wedge and the preload. And they began making a curve, and the curve looks something like this. Okay. Where cardiac output was here, this is the preload or the wedge, and this is the afterload here. Okay. Now, the first thing they did is they said, well, we're going to go ahead and keep the afterload at 0, so when the heart contracts, they will tell the pump, draw out all the blood really fast, and it's a really fast pump. So as the heart was contracting, that pump was actually going and sucking all the blood out of the aorta. So the net pressure inside the aorta was 0. And they found that the cardiac output began increasing as they began increasing the preload up to about 99 millimeters of mercury, where they would have dehiscence on the mammalian heart, that we use for mammalian heart, of the muscle fibers, and the cardiac output will begin to drop down. Okay, so at about this point, it begins to drop down at about 99 millimeters of mercury on the mammalian heart, not on a regular human heart. It's probably higher than that. But at this point, they had the dehiscence of the muscle fibers, and the cardiac output will drop down. Then they told the computer, we're going to repeat the experiment again, but this time, we want you to do is, we want you to increase the afterload little by little. And they began forming a series of curves that began to look like this. And what they found was that the curve actually flattened out as they increase the afterload. So after the afterload was getting increased, the amount of cardiac output that that heart was pumping out was actually beginning to go down. And that makes sense. If I give you a wheelbarrow and it's empty and I tell you run with the wheelbarrow, you can run really fast with the wheelbarrow. If I start putting bricks on the wheelbarrow and I fill it with bricks and I tell you run really fast, you're gonna have a hard time carrying the wheelbarrow. So it makes sense, if you increase the cardiac output by giving it fluids up to a point, and then you begin dehiscing. And if you increase the resistance that heart has to pump against, then the cardiac output begins to drop down. So here, for example, the cardiac output will be very high, and here the cardiac output would actually be lower. Than when it had no resistance whatsoever. Okay. Now, based on this, we translated this also to the human body. In the human body, there is one caveat that you need to know. That instead of having the cardiac output drop at 99 millimeters of mercury, since it's not isolated, you have a lung involved, you begin to drop the cardiac output at about 18 millimeters of water. Okay, now what does that happen? Because at about 18 millimeters of water, you begin leaking into the lungs. You begin going into heart failure. Once you get into heart failure, the hypertrophy of the heart begins to decrease because of the hypoxia, and the cardiac output begins to drop. So in the regular person with lungs, this happens at about 18 millimeters of water, not of mercury, of water. And that's when you begin leaking into the lungs. You go into pulmonary edema, or you go into CHF. Okay, now, remember that 1 millimeter of mercury is approximately 13.2 millimeters of water. So this is not too much. The lungs are very fragile, actually. So the pressure inside the lungs, in terms of water, is not very high. If you have pulmonary hypertension, that's an exception to this. When you have pulmonary hypertension, the arteries become thickened, and they have 4 phases. The first phase, the artery begins to respond to the pressure in the lungs by essentially hypertrophying the media around the artery. If you are a weightlifter and you start lifting weights, you get really tough. So the media begins to get thickened. In the second phase, you begin getting a little bit of necrosis on the media, sporadic, isolated points of necrosis on the media of the pulmonary arteries. This happens because the oxygenation of the arteries, when they're very small, depends on the diffusion capacity of the oxygen, which is, oxygen is a large molecule, it's not very large. So once you begin hypertrophying the media of the artery, that diffusion begins to decrease. And you start getting a little bit of necrosis, point necrosis on different locations. When it gets more severe, this gets a little bit bigger. Now this necrosis begins to grow confluent and begin to associate itself with other necrosis all the way around. And it forms like a little ring around the artery. And eventually you go into the fourth phase, which is irreversible, when it actually begins to constrict, gets replaced by fibrous tissue, which contracts, and then it becomes irreversible pulmonary hypertension. Why do I say this? Because if you leak here at 18 millimeters of mercury, when you have pulmonary hypertension, you leak at a higher level. And typically, this is a defensive mechanism. Many times people have cardiomyopathy, and they will develop a very large heart. And when they develop a large heart, they start developing pulmonary hypertension. Well, guess what? The weight is going to increase. The preload, which is the weight that we measure inside the ventricle, is going to increase. But the lung is going to be protected because now instead of leaking at 18 millimeters of water, you're going to start leaking at about 25, 24, 27 millimeters of water. So you actually protect yourself from heart failure by developing the pulmonary hypertension. Okay? You see the mechanism of this? So this holds, this 18 millimeters of water holds as long as you have a normal person with a normal heart. Once you have pulmonary hypertension, it's protected, and you actually can push fluids a little bit longer to increase the cardiac output even more, because it is protected from developing pulmonary edema and CHF because of pulmonary hypertension. Now, many of these patients come into the hospital, and they will come in, you look at the chest x-ray, and the chest x-ray is, it's clear, and somebody puts a swan gas on the patient, and he measures a wedge of 25, and the first thing they do is they go and they hit him with diuretics, and the guy becomes hypotensive. And they become hypotensive because they're depending on this curve to maintain the cardiac output, and they're essentially moving down the curve, decreasing the afterload, and the cardiac output drops as you decrease the preload on the heart, the wedge on the heart, and the guy becomes hypotensive. He was depending with a large heart on the freestanding mechanism, and on this protection on the lungs to be able to function with a wedge of about 24, 25 without going into pulmonary edema, okay? Now, understanding that caveat, and that's an exception to the rule, now we're gonna do the same thing here. So let's draw the curve again in a more realistic fashion. And can I erase this? Everybody understand this? Okay. Let's draw the curve again a second time, but this time what we're going to do is we're going to start applying it to clinical practice and clinical management of patients, okay? So let's put it here. Okay, so cardiac output. So this is the original curve. We're now going to associate it with the 18 millimeters because of the loads are going to be associated with it. And it's going to drop, it's going to flatten out as I increase the afterload. And the afterload, we're going to understand by this the pressure or the resistance to blood flow when the heart contracts and opens up the aortic valve. It's going to be the preload, and the preload is going to be essentially the wedge or the filling pressure on the heart. So far, everybody with me? Everybody following this? Okay. So now let's start taking some clinical cases and using this curve, this three-dimensional curve, to actually see how we can handle a patient with that comes in shock. Okay, so the first case I'm going to give you is I'm going to give you a case that comes in with bleeding. Okay, bleeding. And I'm going to put here the wedge, I'm going to put here the afterload, and if we have to, we'll add some stuff in here, as we need to. So on this particular case with bleeding, how do you guys expect the wedge to be, high or low? The wedge, the filling pressure on the left ventricle is going to be high or low. The guy comes in shock. Low. So the wedge is going to be low. Now the guy, when you touch him, is going to be clammy, diaphoretic, he's bleeding. What do you think? He's releasing epinephrine. What does epinephrine do to the peripheral vascular resistance? So what do you expect this thing to be high, right? Okay, so where am I on the curve over here? I am with a low wedge and with a high afterload, right? So the first thing I'm going to look at when I have a patient, the first thing I'm going to take care of is going to be the blood pressure. Okay. In this particular case, before you do anything else, I'll tell you why that later. But first thing you always look at is the blood pressure. Then you start looking at this. So the guy comes in with a blood pressure of 60. He's bleeding. Very obvious. I need to fill the tank up. When I fill the tank up, okay, I'm moving this way along the curve. I'm increasing the cardiac output. And this reflex mechanism, which is secondary to the epinephrine discharge from the shock, is going to reverse itself. So the treatment for a patient with bleeding is going to be volume. Volume to replace the low wedge that the guy is losing, okay, and revert the curve and get back on the ascending limb of the curve. That makes sense? So far, so good. Okay. Let me give you a second case. Let me give you another case that somebody comes in like we have the other day, a patient in septic shock. Okay, now in septic shock, you have endotoxin being released into the bloodstream. These endotoxins are vasodilatory endotoxins. They essentially open up all the arterioles, okay? And the blood pressure goes down the bar, okay? So what do you expect the afterload to be? Low. Afterload is going to be low. What do you expect the wedge to be?
High.
Why? No. What do you expect it to be high?
Because I figured they worked opposite.
Not necessarily. This is what you need. Okay, let's reason this out. Let's reason this out together. Okay, you have vasodilatory effect. Okay, everything is open. What happens with the blood return to the heart when you open up all the vessels? It goes down, right? If you open up all the vessels, the blood return to the heart is going to be low, right? So the wedge is going to be low. Okay, the wedge is going to be low. So now I have the situation where I have a very low afterload, but a very low preload also. So now remember that the blood pressure depends also in essence also of the tonicity of the artery. So how do I treat this patient? What do I give this patient then? Okay, I go back to the curve. I need, let's suppose I'm down here. What do I need to give him to increase the cardiac output? Fluids. So I give him fluids. Right, so I give him fluids to move up the ascending limb. So you see how I'm beginning to use the curve now? So I'm here, I'm going to give him fluids to go up the ascending limb. But the blood pressure also needs a little bit of support. My afterload is way low, it's way down here. What can I give him to increase the afterload? Vasopressin. You can give the patient level fed, okay? Level fed and IV fluids. I usually give with IV fluids, you give him a fluid bolus, 1,000 cc's, 2,000 cc's, and they have a protocol here for that. And if he doesn't respond, then you go to level fed as a second option, okay? But first we fill up the tank. So I'm moving up this curve in here by filling up the tank, filling up the cardiac output curve, and then give him a little bit of support for the things to actually stabilize the blood pressure, okay? That makes sense?
Yeah.
Okay, good. Let's go on to the clinical case. We have a patient now that comes in with congestive, with hypertensive crisis, okay? The blood pressure is very high. The guy comes in with a blood pressure in the range of 250, all right? And the guy is in pulmonary edema, CHF, okay? So now, what am I over here? Is my afterload high or low? High. I'm gonna be way out here. Blood pressure is very high. What happens to the preload? It's going to be high or low? It's in pulmonary edema. It's in CHF.
High.
It's going to be high too. I'm going to be way out here. Way out here. Okay, so I'm going to be way out here on the curve. Probably on this side of the curve. I have a very high afterload, a lot of resistance to the cardiac output, and at the same time, I have here a very large preload, so my inotropy is down. Now, the blood pressure is good. I don't have to worry about the blood pressure, but I have to get the blood pressure down in order to get the guy out of heart failure. So what can I do? What can I use for this patient? What do ACE inhibitors do?
They stop from angiotensin 1.
Right, and what does it do to the blood pressure? What does it do to the blood pressure? You decrease the blood pressure, so you can give ACE inhibitors, okay? More aggressively, if you have somebody like this, you can go with what you call this natride, natroprusiate, to bring the blood pressure down and start moving this way on the curve and increasing the cardiac output. From doing anything here, just by going this way, increasing cardiac output because my curve begins to rise up. Okay, that's number one. Number two, I can give the guy diuretics to move also from here to here. Enough diuretics to get him out of the heart failure, increase the inotropy, and afterload reducers to move down this curve and go into one of these curves over here, which has a higher cardiac output. Make sense?
Yes.
Okay, so I can give this guy diuretics, and I can give this guy natroprusiate, vasodilators to do this, okay? So this is high, and this is high, okay? Very good. Let's take another case. Somebody comes in now with CHF, okay? And the CHF is, it's mild, it's not pulmonary edema, but it's CHF. What is the wedge going to be like? You guys tell me, what is the wedge? Going to be high or low?
High.
High, you're going to have high wedge, okay. And the afterload, again, it's a little bit clammy, diaphoretic. It's a little bit sweaty with the shortness of breath. What do you expect the afterload to be? It's going to be also high too. Okay, notice that these two are very similar. So what can I give this patient over here? Diuretics, number one. Okay, and then ACE inhibitors to drop down the afterload reducer and move up the curve. So you see, all I'm doing with this curve is finding out with the clinical condition what I am in terms of wedge and afterload, okay, finding out what I am on the curve, and then doing the appropriate therapeutic intervention to move this way to increase the cardiac output this way, or this way, or this way to increase the cardiac output, whether I have a very high wedge or a very low wedge. Make sense? Okay. Same patient, now this patient comes in with mitral regurg, CHF, but he has pulmonary hypertension. You put in a swan gas and the wedge is going to be high, very high, 25, okay, 25. And what do you expect the afterload to be? It's going to be increased also. He's in heart failure. Okay, so the wedge is going to be high too here. Okay, now, here the pathophysiology is a little bit different. I have pulmonary hypertension. Remember that I told you with pulmonary hypertension, you are protected on the lungs even with a higher wedge. So the guy has a blood pressure, let's say he has a blood pressure of 90 systolic. Which normally is what you run with people that have pulmonary hypertension. They tend to have resistance to blood flow. 90 systolic. Can you give this guy diuretics?
No, because
You're going to probably drop the guy down. So what can you use for this guy? Beta blockers are going to drop your inotropy even more, so you're going to go down this way on both sides. Okay, how about an inotropic agent? Okay, when I use an inotropic agent, this whole curve is going to move up. It's going to shift up. Okay, so if you have the curve here and you give them inotropic agents, everything is going to move up. So you're going to increase the cardiac output by moving the whole curve up. So you can give the patient Wtrex. Okay, or dopamine. Okay, definitely not Levophed. Okay, why not Levophed? Levophed is a pure alpha stimulant. Okay, it generates a lot of afterload, but doesn't do anything to the heart. So if you have somebody with a low blood pressure that has a high wedge and a high afterload already, and you give him Levophed, you try to bring that blood pressure up. What you're going to do is you're going to move up this way of the curve, and what's going to happen to the cardiac output? It's going to go down. So you don't want to do that. You want to give him an inotropic agent like dobutamine, which has a vasodilatory effect peripherally, but at the same time, it increases the inotropic state of the heart. So Wtrex will be a good choice. Dopamine will also be a good choice in low dose. In higher doses, it tends to have also a little bit of elevation of the afterload. But you can give him dopamine low dose, 2.5 miles per kilo per minute, or renal dose, or Wtrex to try to increase the cardiac output in here by shifting the whole curve up and improving the afterload by dropping it down a little bit with the vasodilatory effect, and also with the dropping the wedge down with increased contractility on the heart. Okay. So you see how I'm using this curve, but this curve is so important in terms of handling a patient with hemodynamics. Okay, this curve can be found in a book by Bramwell called Mechanism of Contraction of the Normal Filling Heart. If you look at the book, it has a lot of graphs and a lot of curves. And this curve, which I thought was the most important curve, is hidden in a little corner of a page about that big, okay? You have to look at it with a magnifying glass and you say, aha, this is the curve that I need to use. So that little curve over there actually helps you determine a lot of information how to handle a case. Let's go to another patient now. Okay, so we have these patients over here. We have discussed bleeding, septic shock, hypertensive crisis, CHF, pulmonary hypertension with heart failure. Let's talk about another case. Let's talk somebody comes in with a myocardial infarction now, with an MI. And he's in CHF. Blood pressure is 60 systolic. He's in shock. Okay? He's clamming diaphoretic. What do you think that the afterload is going to be like if it's clamming diaphoretic? No. Oh. Whenever you see somebody clamming diaphoretic, you are releasing epinephrine, and that's what you're sweating. You're constricting all the peripheral vascular resistance, okay? So the afterload is high, even though the blood pressure is 60 systolic. It's 60 because the problem is that this guy is way down here, and there's the inotropy is over way short. Remember that you can drop the cardiac output by moving this way past the peak of the curve, or by moving this way by increasing the afterload. In this case, the guy has a combination of both things. So he has a high afterload. What do you expect the wedge to be like? His heart failure is going to be increased. Again, you see here that you have elevated wedge, elevated afterload. Now, this patient, obviously, I cannot give this guy a diuretic. I can give him a diuretic, but if I give him a diuretic with a blood pressure, he's going to crawl. So the first thing I'm going to do is first take care of the blood pressure, always. So you always go for the blood pressure first, stabilize the blood pressure, and then you do the therapeutic intervention. Blood pressure in this case is 60 systolic. I need to bring it up. Can I use Levophed, which is a pure alpha-adrenergic blocker? Afterload is high. Should I use Levophed? No, if I use Levophed, I'm going to move on this curve farther down. I'm going to increase the cardiac output even more. Okay? You see it? So, what can I use? Well, I can use dopamine, or dobutamine to try to increase the inotropic state of the heart also, and get the guy out of the increase the blood pressure a little bit. Then, after the blood pressure goes up, let's say to 110, that has secured a blood pressure hemodynamically, now I can give him a vasodilator and a diuretic. I can put him on nitroglycerin, drop the preload a little bit, and move, if I'm on this side, move on the curve a little bit this way, okay? And I can give him a diuretic also with the same reason, move over in this way over here. Now, when talking about vasodilators, you need to make a separation between nitroglycerin and alpha-adrenergic vasodilators, okay? if I use nitrite or I use ACE inhibitors, I mostly dilate the arteries. Okay, I'm going to be mostly arterial dilatation. Nitroglycerin is mostly venous dilatation. So nitroglycerin, in this particular case, will drop me the preload, which is okay. I need that, so I'm going to move this way on the curve and go up on the cardiac output curve. So if I use nitroglycerin in a patient with heart failure, that's good because I'm dropping the preload. At the same time, it's not going to do much to the blood pressure, okay? Now, I can also use nitroprusiate. You can use it also, drop the afterload in here, but it's not going to drop the wedge. So if I use nitroprusiate, it's going to be mostly working on the arterial side of the equation. If I use nitroglycerin, it's going to be mostly working on the venous side of the equation. One is going to drop my afterload, the other one is going to drop my preload, okay? So in this particular case, I get onto butamine, I shift the pressure, the curve up with an inotropic agent. Now I'll give him a little bit of diuretics, a little bit of nitroglycerin, and I move down the curve this way. Let's suppose I was at 24, I go down to 18, my cardiac output rises immediately. At the same time, the reflex mechanism of epinephrine release begins to decrease and the guy begins to feel better. Most of the time, that's most of what you need. If he doesn't respond to that, then the next step, after you have done those preliminary things, an inotropic agent, nitroglycerin, and maybe ACE inhibitors to drop the afterload, there's going to be hemodynamic support, either with an impeller device where they put a catheter inside the ventricle, which actually takes the blood and pumps it out, or with an intra-aortic balloon pump, which is not used very much now, but it was used in the old times when I was, doing my fellowship in cardiology. They would put it into the blood. And the way that works is that they go ahead and they put, you have the aorta, it's at the femoral arteries, they put a balloon inside the aorta. And when systole takes place, the balloon deflates. When it deflates, it essentially creates a vacuum inside the aorta. And that vacuum essentially drops my afterload tremendously over here. So now the heart muscle can contract without feeling any resistance, number one. Number two, when in diastole, it inflates again. When it inflates again, now it displaces blood and it pushes blood down and up into the other organs. So essentially, it's a ventricular assist device where you actually are assisting the ventricle to beat in systole by reducing the afterload, and then when the aortic valve closes, then it expands again to actually push blood into the periphery, push blood into the other main organs. The only contraindication to use this if you have severe aortic insufficiency, because then you're going to leak back into the ventricle when it expands, and you can actually essentially wipe the ventricle out. Okay, make sense? Okay, so as you can see, this curve is very important in terms of where you are hemodynamically and how to handle a patient. Whenever you have a doubt, what you need to do is, number one, look at the blood pressure. My blood pressure is low. Why is it low? Is it in failure? Is it septic shock? Is it bleeding? Is it cardiogenic shock? Okay, bleeding. Okay, I need to move on the curve. I need to replace, drop the afterload, but I need to replace the wedge factor first. So you look at the blood pressure first. Number one, you look at the blood pressure. Number two, you're going to find out what are the reflex mechanisms that are taking place. So look at the reflex mechanisms. Okay, so if you have a low blood pressure and you have diaphoresis, that is coming because you have epinephrine discharge because of all the metabolic stress. That's a reflex mechanism. Number three, you see how this mechanism and this blood pressure affect the curve. This particular curve. And then you correct the main problem first. Okay? You correct the main problem first. Always paying attention to the blood pressure. So the first thing you do in a patient that is hemodynamically unstable is go for the blood pressure, stabilize the blood pressure. Then go after all these other mechanisms and reflexes to stabilize it even more. That makes sense? Any questions? Doubts? No? Sure? See a lot of blank faces in here, but that's okay. All right, but does this make sense? So the logical sense, you see why I thought this curve was so important when you're handling with people with hemodynamic problems, because it tells you right off the bat where you are hemodynamically with the patient.
I'm sorry to interrupt. What would you do if they had kidney problems though?
Kidney problems, what type of
Yeah.
renal insufficiency or in dialysis?
Yes.
In dialysis, you have a problem because now you cannot affect the volume. You need to either dialyze, right? Several tricks you can do. Very good question. Okay, let's suppose you get somebody with heart failure, and heart failure would be the worst one. Heart failure, and the guy is hypotensive. Okay, all right. He's already volume overloaded. I cannot get the fluid out because of the kidney failure. Okay, so I'm going to have to go immediately and call somebody to bring a machine to start dialyzing the patient. Well, meanwhile, I can do several things to actually stabilize the patient. I can use a vasodilator and decrease the venous return to the heart. I can use Dopitrex to increase the inotropic state of the heart. So the blood pressure is low. I'm going to stabilize the blood pressure first. Number one, Dopitrex, move up the cardiac output, shift the whole cardiac output curve upwards and get more cardiac output that way. Number two, decrease the preload. Decrease the preload because the guy preload is actually throwing him into failure. So I'm going to give him either vasodilator. Diuretics won't work, so I cannot use diuretics. Or I can use vasodilators, rotating tourniquets, or nitroprusiate to drop the afterload a little bit once it's more stable, or drop the preload with nitroglycerin or rotating tourniquets while I get the guy to bring in the dialysis machine. Let us suppose that you are now in the middle of the boondocks and there's no dialysis machine. What else can you do? What else can you do then? You already use rotating tourniquets. Rotating tourniquets, and you use. No, you do bleeding the guy. You actually bleed the guy out. You bleed the guy out. Yeah, you bleed the guy out. Okay, in the old times, before we had all these medications that are now very fancy, somebody in heart failure would actually get a treatment, would actually put a catheter inside and bleed the guy out. And you decrease the afterload that way. Okay, remember your volume expanded, your kidneys are shut down, your volume expanded, all right? He's in failure, you try to bring nitroglycerin, Dopitrex, nothing else works, rotating tourniquets. Fine, I'm going to bleed the guy out now. Take out maybe a liter or so, or 2 units of blood. All right, he'll recover that later. But I said get him out of the acute emergency. Then I finally get my dialysis machine and start putting him in the dialysis machine. Make sense? Yeah. All right. So this curve is important because it tells you where you are in terms of hemodynamics when you're handling a patient. And the most common thing you're going to be seeing here is going to be one of two things: septic shock, probably number one, in 85% of the cases, and number two, bleeding. Okay. Very rarely you're going to get a heart attack in this hospital, mostly because we're not a cardiac cath facility. So you're not going to get people here coming in cardiogenic shock with ruptured valves, with ruptured, different things. Okay. All right. So far it's understood. Okay. Let's see how much time I have. 2:30. I have 20 minutes. So now we're going to do now talk a little bit about aortic stenosis. But before I talk about aortic stenosis, let's talk a little bit about 2 equations that you guys need to know. And you guys thought that when you left high school, you would leave math behind, right? I have news for you. Here we go. People are going like, okay. All right. Everybody knows what a garden hose is. You have a garden hose and you have a piston, right?
Yeah.
So if I close the piston, the thing shoots out farther away. Okay. I'm going to talk about the Bernoulli equation. So who was Bernoulli? Bernoulli was an engineer in Florence back in the 1800s, and he was coming from a family of engineers and scientists. And he was given the task of finding out why some fountains would spit out water very high and others would not. They couldn't figure it out. So they gave him the problem. And he figured out the Bernoulli equation using the work energy theorem, which we'll derive in 1 second. So before we do that, we need to derive the continuity equation. This is one that you see with the garden hose when you open up the piston and the piston shoots out water really fast, far away. Okay. So let's suppose that I have laminar flow in a structure like this, like a cone, and that I have here an area 1 and an area 2 over here. And I'm going to play a little trick. Normally this is done with differential equations. If I go into differential equations, it's going to be very problematic and way beyond our reach over here. So I'm going to do it algebraically. Okay, so we have an area 2 here and an area 1 here, which we can say this is short. Okay. I'm going to take a small aliquot of time, a small interval of time. I'm going to call it delta t, which is going to be the same for both. And I'm going to have a velocity here, v1, and a velocity coming out here, v2, which I expect to be higher because of the piston when I'm closing it down. Okay. Now, the amount of mass coming in here has to be equal to the amount of mass coming out from here, right? That makes sense. Whatever comes in has to come out. Okay. So if you look at a cylinder, okay, the volume of a cylinder is going to be the height times the area, right? And the mass in that cylinder is going to be the density times the volume, okay? So if I have a density rho, I can immediately write an equation that the amount of mass coming in here is going to be area 1, this in here, V1 delta T, is distance or height, okay? Because velocity times time is equal distance, right? Times rho, and this is going to give me the mass coming in through here. Make sense? Everybody sees that? Same thing happens with the mass coming out here. I have my little cylinder, I have my velocity V2 here, over an amount of time, delta T, which will move from here to here, times rho. So that's going to give me V2 delta T times area 2 times the density, and that's going to give me the mass coming out through here, which I have over here, right? Make sense? Okay, great. So now we can start canceling terms. So I can cancel this term, I can cancel rho, and I have A1 V1 equals A2 V2. That's the continuity equation. It's called continuity equation because the mass is continuous. Whatever comes in has to come out. Okay. So now we're going to work on the Bernoulli equation. Now I'm going to put this on one corner over there, so I'm going to need the whole blackboard for the next one. So I'm going to leave this in here, but I'm going to put the equation over here. And I'll tell you why I'm deriving this equation. I'm not trying just to play with mathematics, because this is what we use when we determine aortic stenosis and metal insufficiency, and we determine the area. It actually relates the pressure and the velocity to the amount of pressure across the bump. So what did he do? Well, he realized that if you use the work energy theorem, and what is that theorem? It tells you that the amount of work that you do is equal to the change in kinetic energy from the change in potential energy. So if I take this blackboard in here, this eraser over here, and I lift it up here, I have done an amount of work. Now it has potential energy. So if I drop it, now gravity does the work and it moves it back to what it was before, okay? So the amount of work performed is going to be equal to the change in kinetic energy plus the change in potential energy. Now, I know that pressure is equal to force divided by area, right? And I also know from high school that work is going to be equal to force times distance, right? They tell you that work is equal to force and distance. And somebody's going, yeah, I learned that in high school. Okay, all right. Well, I know that force is pressure times area, so immediately can I start writing an equation in here where I have my area 1 times my pressure 1 times this, and this is going to be work. Okay, so let's go over that again. I have force, which is equal to pressure times area. Okay, this is here, okay, times distance, but distance is going to be given by this velocity V1 times delta T. Correct? So now I have this thing over here. I have this one here is force, this one here is distance, and this is work. Right? Make sense? And I have a difference between this side and this side over here. Make sense? Okay. And that's going to be equal to the change in kinetic energy. Remember that kinetic energy equation is 1/2 mv squared. Right? Correct? Okay. But my mass, like I explained before, is going to be equal to rho, from what I did before here, is going to be equal to rho times the area of the cylinder, A1, on this side here, times the velocity V1 delta T. So this here is going to be my mass, times V1 squared,
Please dial 6810.
times V1 squared, that's 1/2.
Dr. Cabral, please dial
Okay.
6810.
So this here is mass, this is velocity 1 squared, and this equation is my 1/2 mv squared. Make sense? Okay. So I plug that in here now, and I make it equal to rho A1 V1 delta T times V1 squared minus rho A2 V2 delta T times V2 squared. Where V2 squared is the same thing that's happening here, is also happening here, okay? So I just plug in here. So this is kinetic energy here, plus the change in potential energy. Now, potential energy, I'm gonna do a little trick, okay? And I'm gonna say that these two things are very close together in terms of distance. Potential energy is essentially mass times height times acceleration of gravity, okay? So it's GH times mass. So if I have this thing here, and I lift it up here, okay, this is the potential energy. It's the mass times acceleration of gravity, okay? All right, so if this thing here is equal to the mass, okay, which is gonna be the same thing, the mass here is gonna be given by this, okay, I'm just gonna write mass times H1 times gravity minus M H2 times gravity, where this distance from here to here is very small. This term can be neglected because it tends to be very, 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 very small as compared to the other large term, okay? So I'm functioning mathematics here a little bit. Make sense? Okay. So, since the distance between these two things on the heart is very small, about that size, okay? When you're measuring an aortic valve, you're measuring the velocity right here and right here. And that is usually less than 0.5 centimeters. For all practical purpose, the potential energy is going to be the same. So I can discard this term to facilitate the equation even more. So now, I'm left with this equation over here, which looks very complex, but it's actually not very complex, okay? Because remember that from the continuity equation, A1V1 equals A2V2. So I plug it in here now. And whatever I have A2V2, I'm going to substitute for A1V1, because it tells me it's the same. Okay? And now start canceling terms. So this is going to cancel, this is going to cancel, this is going to cancel, and this is going to cancel. So now I'm going to write the equation as P1 minus P2, which is my delta P or my gradient, my pressure gradient, is going to be equal to 1/2 rho times V1 squared minus rho V2 squared. Make sense? Okay, so now I have a new equation. But I'm not going to stop there. I'm going to simplify it even more. How I'm going to do that? Well, I'm going to go a little bit into calculus now. Okay, now remember that when you went to high school, you learned that a differential, which is a change of rate, okay, was given by a definition, right? Okay, and what we have here is a v squared, which is essentially a parabola, right? Remember this thing here, y equals x squared, and it will graph like something like this, right? That's a parabola. Okay, let's examine the parabola a little bit here for a second. Okay, let's suppose that I have here 0, 1, 2, 3, 4, 10. And I'm going to make a table. Okay, and say 1 squared is 1, 2 squared is 4, this is 9, this is 16. This is the square term. Look what happens between here and here. The difference is 3. Difference is 5. Difference is what? 7?
Yes.
Next one is 5 is going to be 25. The difference between 16 and 25 is going to be what? 11? Or 14? 9. 9. Okay. So notice that I'm increasing by 2 the value over here. Okay, I'm increasing by 2 the value of each term. So when I have 100 squared, it's 100. If I have a very low velocity here, let's say 2 squared is 4. For a practical purpose, 100 is much bigger than 4. So again, I can discard this term over here, because it won't affect my final velocity problem. So I can also do another approximation here. So now I'm left with a simpler formula called the delta P, okay, which is this one here. It's going to be equal to 1/2 rho times V2 squared, or V1 squared, or this V2 is squared, where V2 is going to be the higher velocity. But to simplify it even more, rho is roughly, the density of roughly about 8 times the density of water. So this is gonna be delta P approximately equal to 4V squared. And this is what they call the modified Bernoulli equation, which actually relates velocity across the aortic valve with a change in pressure across the aortic valve. Okay, everybody understood that? Okay, is it right? Okay, so when they tell you, when we measure velocity in terms of aortic valve, we go to meters per second, okay? The aortic valve reading is not supposed to be more than 16. If you have 2 times 2 is 4 times 4 is 16, anything above 2 meters per second begins to give you already aortic stenosis. Okay, using this equation. And this is, by the way, what they use on the echoes to calculate the valve area. So they calculate the valve area with the aortic stenosis by using these two velocities in here, by measuring the velocity above and below the valve, okay? And then you have the aortic valve here. You measure this distance, which is this distance over here, the area here. And then you measure the velocity here, and then by a simple algebraic equation, you get the second area, which is the area you want over here, by essentially substituting one over the other, okay? And you get the aortic valve area. And this is what they use in ultrasound. So why do I go through all this problem? Because when we're dealing with aortic stenosis, we're dealing with a totally different breed of cat. Okay, it's the worst disease you can have in terms of valves. Okay, aortic stenosis, from all the valve disorders that I have, the one that I have lost most patients to is aortic stenosis. It's a killer. It's a bad disease. It's worse than matter rehabilitation. Why? First of all, aortic stenosis, as it begins to develop, okay, and then you begin to increase the gradient, what begins to happen is you start getting hypertrophy of the heart, number one. Then you start getting into a phase where the heart begins getting bigger, and then eventually you go into heart failure, okay? That happens when the valve area usually is below 0.5 centimeters squared. Between 2.5, above 2.5 is normal. Between 1.0 to 2.5 is moderate. 1.5. Between 1.0 to 1.5 is severe, and less than 0.5 is critical. Okay? Once you have a patient with aortic stenosis, and that curve that I showed you with the preload and afterload goes to hell. Okay? Totally wipes out. It's a bad disease. Number one, you're going to have a patient that comes in decompensated with aortic stenosis with heart failure. The mortality with aortic stenosis with heart failure is 50% in 2 years. If you don't treat it, 50%. Okay, I had a case at Winchester one time with a physician that I was taking care of, and the guy came in with heart failure, and we were able to get him out of the heart failure by, like we say in Spanish, por un pelito, you know, a little hair, okay, to get him out of the heart failure. And I told the guy, we need to move on this guy, he needs to get a valve replacement, okay? No, he doesn't want to because he's afraid, because of this, because of that. You know, he wasn't afraid. Mira, we need to move on this guy. He won't make it a second time. Okay, no, because he doesn't want to. He wants to think about it. Don't think about it. This guy is as tight as yes, just came out of heart failure, this is bad. Guess what? While in the floor, the guy went into heart failure a second time. This time we couldn't get him out and he died. So why is it so deleterious? Number one, you have a fixed obstruction. You have a fixed obstruction on the valve in here. This ventricle decompensate. This ventricle now has, if you look at the curve, this ventricle decompensate. This guy is going to become claminatorated. Your afterload is going to be high. But this afterload that is high cannot be fixed no matter what you do. It's a fixed obstruction. You can give him nitroglycerase, nitroglycerin, ACE inhibitors. You have a fixed valve obstruction that increases the afterload, from which there's no solution. Number two, the wedge goes up high, and it goes on this side over here of the curve. So now you have a problem because the guy is hypoxemic, it drops the anotropy, it goes into heart failure. You cannot fix the afterload, he's hypotensive. If you give him an afterload, if you give him an inotropic agent, the only thing you can do is that. You might be able to bring the blood pressure up. If you give him levofed, you kill the guy. Because levofed will increase the afterload even more, and that heart is not going to recover. And if you give him diuretics to try to bring him down, it becomes more hypotensive. So you're in a vicious circle. You can't get him out. The only thing you can do in this case is that you transfer the guy out on dobutamine or dopamine, cross your fingers. You call whatever hospital they do invasive procedure. listen, I need an emergency valvuloplasty. They go in and they open the valve up as an emergency, open it up, give him aortic insufficiency, but at least the guy has forward output now. And then they worry about fixing the valve, okay? So aortic stenosis is a bad disease. It's the disease that I dread the most. From all the valves, it's the one that will kill you suddenly. To give you some statistics, if you have aortic stenosis and in 5 years, if you have symptoms of shortness of breath or heart failure, 50% mortality. If you have syncope, 50% mortality in 5 years, not in 2. If you have angina, chest pain or angina, 50% mortality in 5 years. That means 50% die. Okay, 50%. You start with 100 patients. In 5 years, you have 25 alive. In another 5, you have 12 people alive. And if you have heart failure, it's in 2 years. You have 50% dead in 2 years. In 4 years, you have only 12 people left or 25 people left. Okay, so it's a bad disease. So if you have aortic stenosis, this curve doesn't really start helping you too much because now you have a fixed obstruction. Mitral regurg is the other, and this is why we talked about the Bernoulli equation, because this valve area is determined by the echo. When we do the ultrasound, that's how we actually find the valve area, by the Bernoulli equation and the gradient. If you have a gradient that is more than 45, more than 50, you have severe aortic stenosis. Normal gradient is less than 16. 16 to 40, mild to moderate, 40 to 50, moderate, more than 50, severe, more than 7 is critical, okay? So aortic, and we find that gradient using that little formula that I gave you, that 4b squared. And the other using the continuity equation. So we put those two things together and we say, this guy has severe aortic stenosis, we need to go for cardiac catheterization, okay? Clinically, these patients will exhibit several characteristics. Number one, a lot of distal exertion. If you listen to them, they're going to have a crescendo murmur, okay? The murmur is going to look like this. And this happens as opposed to mitral regurg because when S1, S2, after the first heart sound, the pressure begins to increase on the aorta very fast, okay? And as the aorta is beginning to feel, the resistance in here begins to go up, the afterload begins to come up, and the cardiac output begins to decrease. So hence, you begin to decrease over here. So the first phase begins to contract when it's pushing into the aorta, then the resistance on the aorta begins to increase, cardiac output begins to decrease, and you get the diamond shaped murmur. Mitral regurg is an systolic murmur. It actually has the opposite effect. It's like this. Why? Because now you're pushing blood into a low resistance area. The problem is totally the opposite from the aortic valve. Here you're pushing blood into a high resistance area. With mitral regurg, you're pushing blood into the atrium. When you push blood into the atrium is very flexible, very distensible, opens up really fast, so the pressure doesn't increase too much, hence the murmur stays holosystolic most of the time. There's no increase in resistance to the murmur. As opposed to the aortic valve, with the resistance increasing here, drops the volume down and the murmur decreases a little bit towards the end. Okay? Now, mitral regurg is a valve problem that gives you signs and symptoms. It gives you mostly heart failure. When you're going to see somebody with mitral regurg as opposed to aortic stenosis, it's not that they go into shock. They go into heart failure. They develop difficulty breathing, difficulty with exercise, they go into heart failure. You have more time to deal with mitral insufficiency. I have a patient now that has mitral regurg on the floor that has pulmonary hypertension. By the way, this is the most common cause of pulmonary hypertension is mitral regurg. So I have somebody now with pulmonary hypertension on the floor and mitral regurg. I'm trying to get him to get the valve clipped. He's 91 years old. Obviously, a valve replacement is going to be very risky at this age. But they can do clipping of the valve now. They go in and they put clips on the valve and they close the valve area a little bit. That is new, and they do it through a catheter, very non-invasive. So you decrease the amount of preload that you have on the valve. Because what happens with the mitral regurgitation is a disease of preload, whereas aortic stenosis is a disease of afterload. In aortic stenosis, the afterload is high. Okay, that's what kills you. In mitral insufficiency, it's the preload that is high, because you pump blood back into the atrium. When you relax, all that blood comes right back at you. So your preload is going to be high. So you have more time to work with mitral regurg. You can treat it with diuretics, you can treat it with nitroglycerin, and you can move on the curve this way, okay, while giving diuretics, because normally they're not hypotensive, they're usually in heart failure. So you can give them diuretics, move this way, give them preload reducers like nitroglycerin or ACE inhibitors, move down this way, and the patient will improve. Not so with aortic stenosis. You have a fixed afterload, And once they begin decompensating, it's very difficult to get them out of the thing. All right? How much time do we have? 1 o'clock, sharp. Okay. Does that make sense when I explain to you? Okay, so you see what the value of that curve that I pointed at you, and what I think. So now you can go back to any cardiologist out there and says, I know how to do the Hemodynamic equation, and impress them. Okay. Okay, any questions, any doubts? No questions, no doubts? Okay.
What was the second disorder that you were talking about, the disease?
Mitral
How do you say it?
mitral insufficiency. Mitral regurgitation.
Mitral insufficiency.
Yeah.
Oh,
Let me see.
yeah, the